I'm Dean Kereiakes. I'm a chairman of the Christ Hospital Heart and Vascular Institute, professor of medicine at the University of Cincinnati, and clinical professor of medicine at The Ohio State University. I'm also the deputy editor for JSCAI. I'm here today with Javier Escaned, who's the head of interventional cardiology, the Hospital Clínico San Carlos in Madrid, Spain, Brilakis, who is director of the Center for Complex Coronary Interventions and chairman of the Center for Coronary Artery Disease at the Minneapolis Heart Institute, and Bill Fearon, who's a professor of medicine at Stanford University. And we're here today to discuss an important manuscript that's being published in JSCAI entitled Time-Dependent Changes in Coronary Circulation Triggered by CTO Revascularizations. Insights from Intracoronary Physiology. Well, no doubt CTO PCI has become a growth industry, and understanding the impact of successful PCI on immediate and long-term epicardial as well as microvascular domains is increasingly important. Javier, please describe your analysis and share with us what you learned about coronary physiology following CTO PCI.
Thank you very much, Dean. It's a pleasure to be showing you a summary of the paper that is published in JSCAI. Now, these are my disclosures. Now, the starting point for this is that, interestingly, the physiology of occlusion, of coronary occlusion was studied in the early 30s by Greg Biggers and Wouters, other colleagues, using typically models, animal models, to assess what were the changes. But we knew very little about this until the beginning of the 21st century, where we started having a lot of information coming from pressure guide wires fitted with intracoronary sensors, that will give us information about what is going on. Now, of course, one of the reasons why it is important to understand the physiology associated to CTO revascularization is because this is growingly performed in patients in whom we also use physiology to determine whether we want to treat other lesions in the same coronary tree. Also, because we now have the possibility to investigate what are the changes in the subtended microcirculation to the occluded vessel and also to the collateral donor vessels. And from this reason, we thought that it would be interesting to gather the information that was available in the literature, scattered, so to speak, and try to get some information using a meta-analytical approach. Now, if we look at it from the perspective of the PICOS analysis, you see that the population of our study will be CTO patients undergoing PCI, studies that have been investigating this, and in whom intracoronary physiology was performed at pre and post CTO PCI stages, and also in other studies post CTO and a follow-up. So that would be the possibility of looking to changes in the long term. Now, you can see here some of the other aspects of the meta-analysis. I can tell you, perhaps more importantly, that we consider a primary endpoint that was the FFR in any stenosis in the collateral donor vessel, comparing the pre and post CTO PCI to assess if these vessels in the coronary tree in patients who have a CTO, the functional assessment with pressure guide wires was being shifted or being changed by revascularization of the CTO. And as secondary endpoints, we were looking into these concepts of myocardial FFR, collateral FFR, and coronary FFR. You probably remember that these were terms that we were using in the 90s when FFR was born to understand the different contributions of elements in the coronary circulation, the epicardial vessel, and also the collateral circulation to the overall perfusion of the myocardium. In total, we identified 17 studies that were eligible for this analysis, and we extracted the data to obtain relevant questions. if you go to the article, you will find much more information than the ones that I'm going to show, but I'm just going to take some highlights. This is a frequent scenario where people are concerned on whether they can trust an FFR measurement performed in a collateral donor vessel that has a stenosis. So the question is whether performing revascularization of the CTO, that is receiving the collaterals, will modify the FFR value in that vessel. Now, there were sporadic case reports showing evidence about this, some studies looking into this. But if you look now from the perhaps more wider, also perhaps a bit more robust evidence provided by this meta-analytical approach, you can see that the answer is yes. I mean, typically, you may expect, on average, an increase of 0.04 units in the FFR value in the stenosis in the collateral donor vessel once that you have opened the CTO that is receiving the collaterals. So that can be important perhaps at the time of planning revascularization in patients that have, as I say, multiple stenosis in the coronary tree, including a CTO. Another aspect that can be interesting is what happens with the collaterals once that you have opened the CTO. Now, if you look to the acute setting, in the acute setting, you do not see changes in the physiology in the collateral FFR. You do not see any changes. But if you take those studies that have performed a follow-up, and then you look into it, you will find that actually, yes, there is so to speak, an involution of coronary collaterals from a hemodynamic standpoint. You will see, you should expect a decrease of 0.16 FFR collateral or collateral FFR units that follow up in these patients. So that means that consistently, as you can see here, look at the p-value for common effects and for random effects is very, very similar. There's very little heterogeneity among studies. You should expect that there is a regression of collateral support with time once that you open the CTO. And what happens with the microcirculation downstream the occluded vessel? This is something that is interesting. And I will say that these are some of the findings that are more revealing and perhaps more hypothesis generating. If you look to the changes in absolute coronary blood flow assessed with continuous saline thermodilution, which is a modern and pretty robust way of assessing coronary flow from an absolute perspective, you can see that at follow-up, these patients had an increase of about, on average, of 53 milliliters per minute in flow compared to the immediately after opening the CTO. So there is a gradual time-dependent increase in myocardial perfusion downstream the occluded vessel that is not, as I say, that occurs over time. You look to coronary flow reserve, and here we are putting together studies based on coronary flow velocity reserve measured with intracoronary Doppler. You can also see that there is an increase in flow of in coronary flow reserve of about 0.46 points. And if you look to microvascular resistance, well, here you can see a reduction in resistance, microvascular resistance. You can see that depending if you're using fixed effects or random effects, you can see major differences because there are few studies and because the heterogeneity is very high. So if you take the more conservative random effect model, you will see that there is no significant difference, but you can see it with the fixed effect model. So to summarize all this, I believe that this meta-analysis provides some insights on the many changes taking place in the coronary physiology when CTO is opened. At the level of the occluded vessel, you could expect an increase in FFR, an increase also in the coronary FFR, meaning that there is some increase in capacitance of the epicardial vessel over time. You should expect also in the contralateral artery that is providing collateral support to the occluded vessel, an increase in FFR also, and at the level of the collaterals, you may expect an involution, a decrease in the collateral FFR. If you look in the subtended microvasculature, what it looks is like from the baseline to the follow-up, there is an increase in the functionality of microvasculature, which leads to increased myocardial blood flow and decreased microvascular resistances. So thank you for your attention. I'm really looking forward to hearing from you and from your comments.
Thank you very much, Javier. I'd ask Bill and Manos, any initial reactions to this? Any surprise?
Yeah, thanks, Dean, and thanks, Javier, again. Phenomenal work and very practical. What I would like to talk a little bit more and ask you is about that change in the donor vessel, because that's a very common clinical scenario. You have that 50% LAD in the right coronary CTO, and you're wondering, should I treat it, should I not? And it gets very confusing sometimes. And what was very useful to see is that in some of the studies you mentioned, there was an increase up to 0.11. So although the average was 0.04 in FFR of the donor, as you saw, sometimes it can be as high as 0.11. So my take of this is that, we'll have to expect some increase. So if your FFR, for example, is 0.6 in the donor vessel, then that means it's going to be significant no matter what. But I'm just curious about what is the cutoff you're using. Let's say 0.75 or 0.76 or 0.72. What is your threshold, so to speak, for treating the donor vessel? Or do you just recommend that we stop, fix the CTO if we can, and then reassess and then take it from there?
Thank you. No, it's a good point. Well, I mean, of course, the information we can get, from a meta-analysis in that is limited in terms of providing accurate information. But it was very consistent, the analysis of these studies that are available in this increase in 0.04 units. So that roughly, I think that I will say is that if you have, an FFR that is in the region of 0.76, which obviously is significant before opening the CTO, you may consider that probably that stenosis is borderline or is not dire. Let's imagine that you have also perhaps a more clear situation. Let's imagine you have the 0.80 value, okay, in the collateral donor vessel, the stenosis in the collateral donor vessel. Well, you may expect that this will go up. And something that is very important, it will go up with time. This is something that is very important. And that is probably the big difference between case reports, where typically you have selection bias. You only report in case reports those cases in whom you have seen that the FFR, goes up immediately. While in reality, in many occasions, we do not see any change in the FFR immediately. Now, why increases in the long term? Well, for the same reason that we are saying that you see that there are also changes in the microcirculation that take time. So what happens is that when you still are opening the vessel, you will not see the full reflection, the full change in the coronary microcirculation that is going to affect the microcirculation and therefore affecting also the values that you're making in the microcirculation. So that's probably one explanation. So I think it's a practical point, and for I hope it's as much as we can get from the study, but at least we get it extracted from a significant number of patients included in those studies.
Bill?
Yeah, thanks, Dean. Javier, congratulations to you and your colleagues. This is really a great contribution to the literature, and particularly because this is such a challenging area to study. And there's a number of small studies, and it's hard to draw conclusions. And the work that you guys did to accumulate these data into one spot is really helpful. And I think the key message Manos highlighted is this issue with the change in FFR that we see in the donor vessel. But I also found it really intriguing how the physiology supported what we see clinically with CTOs. For example, this issue that collaterals right after you open a CTO can still persist, and the positive remodeling that occurs in the donor vessel, where you ultimately will have an increase in flow, and then the collaterals will sort of involute, as you mentioned, and the changes that has on the microvasculature and the physiology really, explained all that, which is, interesting to see. Now, the question I had, I think getting back to the main clinical message that our listeners should be aware of is this change that you can see in the donor vessel FFR. And Javier, I'm wondering, do you think that it matters which donor vessel it is and where the lesion is? So, for example, if you have a 50% proximal LAD that's supplying robust collaterals to a CTO on the right versus, a 50%, circ lesion supplying collaterals, how might that affect the change before and after opening the CTO with the FFR and the donor vessel, do you think?
Well, my impression is that the larger the myocardial territory that is dependent on the collateral donor vessel, the larger the shift you may expect once that you open the vessel. And again, you probably will need to wait some time to really assess the whole effect of that this has on perfusion. Something that we found, Bill, that was very interesting is that in the collateral donor vessel, when you open the CTO, in the long term, the microcirculatory resistance increases. And you may say, oh, that's bad news. But actually, perhaps it's not bad news. Perhaps what that means is that so to speak, the functional dependent mass of myocardium of that vessel has been reduced now. And as you know, for the same value of pressure, when you reduce flow, that will mean you will immediately increase resistance. In these cases, it's because you have free, so to speak, a mass of myocardium that now is vascularized, or that is supplied by blood by the CTO vessel that has been opened.
Yeah, no, I think that's a great point, and a great thing for the listener to remember is that the donor vessel microcirculation isn't getting worse necessarily. It's just the myocardium is getting smaller, and so the resistance tends to go up. And the myocardium is smaller because you did a good job opening the CTO and supplying blood flow antegrade, and so no longer does the donor vessel need to supply so much myocardium, and so the resistance seems to go up. But it's not really a reflection of microvascular dysfunction. Yeah.
Javier, I had a couple of questions just from the outside looking in, and that is the time dependency. Let me ask you, did I get this correctly? It looks like initially there's a FFR collateral goes up by 0.04, but over some time course, and I also have a question about the consistency of that time course and whether these studies and follow-up were done in a similar time frame so that they are, quote, poolable, okay?
Yeah.
And that is, it goes down by 0.16. So if I were going to really evaluate somebody, I mean, I would probably fix the CTO and bring him back at some later time to get a more realistic and stable collateral FFR. Is that a reasonable assumption?
Yeah, it's a good point. And of course, that is one of the limitations of the meta-analysis, is that you have what you have. I mean, that's the studies that have been performed, and you cannot stretch it, So the follow-up in these studies was variable, but luckily, I believe the minimum time of follow-up in the studies that were less was 6 months. So at least we know that 6 months and beyond, this thing has happened. But it's difficult to say exactly why. Then something that is very interesting, if you remember when we talk about hibernating myocardium, and I think that in many cases in CTO could be a good model for hibernating myocardium. Typically, we have, this graph that demonstrates that there is a time lag from the time that you perform reperfusion to the time that you obtain functional benefit in terms of increasing, myocardial contractility, etc. I think that this study is basically supporting this, but it's providing evidence that probably that is because the time lag obeys to that the microcirculation needs time to recover once that you restore antegrade flow to the vessel. And it makes a lot of sense. There are other studies that are not included in this meta-analysis, but that have demonstrated, if you look, for example, to endothelial function immediately after performing a CTO PCI, that you have lots of endothelial dysfunction. Because, of course, there was no laminar flow, antegrade. You can imagine that all the functionality of these endothelial cells is gone, and that needs some time to recover. And also, Manos, and you have spoken many times about this. You also see that there is a time-dependent positive remodeling of the epicardial vessel distal to the stenosis, which probably, by the way, is a crosstalk also with endothelial cells. So yeah, so that's something that, following what your comment about time, it would be great, of course, to have more detailed information about time dependence or yes, time dependence.
Yeah. Did you ascertain that the technique and technologies were similar? Some of these studies are 12 years old, at least, and whether it's thermodilution, solid state, I mean, maybe some comments about the comparability of these techniques.
Yes, sorry, it was because we have these experts around. I thought that this question was be taken by Will. No, they are not comparable. Although the studies obviously that look into absolute myocardial blood flow, they are measured with the same technique. Is continuous saline thermodilution. The other ones that look into coronary flow reserve, it's true that you may have some differences. That's absolutely true. Luckily, luckily, the discrepancy that you have between these techniques is when you have very high coronary flow reserve values. So if you have a coronary flow reserve value, for example, of 4 in Doppler, then you may have a coronary flow reserve value of 8 with bolus thermodilution. But when you come closer to the range of values that typically you would find in disease vessels like this, it probably makes sense. In any case, you can see a directional agreement in terms of improvement of flow. So we could argue, about the magnitude of the improvement, but I think that the good thing is that the studies are showing a directionality of improving coronary flow reserve once that you open the CTO.
It's a great point, though, Dean. I think that we really need, and we're getting there. I think we're starting to become more uniform in how we perform these physiologic assessments because there was a lot of variability over the years, and I think people have learned a lot about a way of standardizing it. And I think, we're just at the beginning now. Now that we're getting there, we can apply these techniques in a more universal fashion in a much larger population, because I think, this is a small group of patients, probably, I presume, pretty select population, because these are patients that were, felt to deem, appropriate for CTO revascularization. And I brings me to another question I had for Javier is, is there a role for physiology up front to identify patients who might benefit from CTO revascularization? Or, I mean, it's a challenging situation because the vessel's occluded. What are your thoughts about that? Or is it totally a non-invasive assessment and clinical assessment about whether or not, you should be opening a CTO?
Unfortunately, from the standpoint of intracoronary physiology, I'm not aware of any technique that can be applied. Should the vessel be opened, there is the Vaca Pereira's group in London reported on the value of wave intensity analysis to be able to anticipate viability of subtended myocardial territory. And we also had some work also with wave intensity analysis, particularly with backward expansion wave in diastole, which correlates very well with the density of capillaries, which sometimes, something that might be well related to viability. But unfortunately, as you say, because the vessel is occluded, I'm not aware of any technology that can be applied from the intracoronary perspective. I don't know if if in the near future we will have something from the non-invasive standpoint, but at this point, certainly for this.
Excellent. What would you say are and I think this is a segue from Bill's comment, the clinical correlation, if you will, or clinical implications of these changes. I mean, I've always used angina, to be honest with you, and then we look for viability with either CMR or PET scanning, and then we make a decision about risk benefit. Is there anything that is additive to that system or strategy can be derived from the coronary flow analyses?
At this point, I think that what we have learned from that is practical is, and we dedicated to this the first part of the discussion, the impact it has on pressure indexes used in a contralateral vessel or in a collateral donor vessel. This is something that obviously you must take into account. Probably the next thing that then you could obtain, and this is something that we need to see, is if these measurements that you're obtaining immediately after opening the CTO, if there is anything in these measurements that you obtain that are predictive of further evolution. But as I say, in a way, the meta-analysis is like a sort of lesson on the physiology of CTO, so to speak, obtained from scattered studies. I certainly will trust much more in terms of deciding what to do upfront with the patient. I will decide much more in, as you mentioned, on a PET or magnetic resonance or any study that is telling me about the amount of subtended myocardium, the viability of that particular myocardium, and that, of course, put together with the symptoms of the patients, because for the time being, at least in the EuroCTO study, was the study that demonstrated that what you may expect when you open CTOs is the first place is improvement in the relief of angina. I mean, this is something that certainly we take into that. From there onwards, of course, I mean, we all perform CTOs in cases where we feel that it is indicated to perform revascularization because there is a large mass of myocardial territory, and that this cannot be achieved by any other means. Would that make sense, Manos? I don't know if you agree about that.
No, I completely agree. Because as you said, the problem with physiology in the CTO is you cannot do it up front. So at least for the occluded vessel, as everyone agreed, you cannot do this up front. And actually, I would take it a step further. I think what you said, the temporal changes. After a CTO, you probably should not be doing physiology immediately because, as you said, things are going to improve over the next few weeks or months. So even if it doesn't look perfect, and that's a common thing we do in CTO, is we say, let the vessel get back to its baseline state, see how the patient is responding. Even if you do an FFR, it may not be optimal, but it's going to improve over time. And that's exactly what you showed in the meta-analysis.
Yes, that's a very nice way of putting it. It's a very important way, practical way of saying this study using intercoronary physiology demonstrates that you cannot rely on physiology immediately after performing the CTO revascularization. That's very nice.
Excellent. Any closing comments, Bill, Manos, or Javier?
Again, congratulations. And I think the take-home message here is that there are changes in physiology, particularly in the donor vessel, that we need to be aware of and take into account, and that there's a time dependency there that can affect it even, weeks to months after you've opened the CTO.
Yeah, congratulations, Javier, again. Phenomenal study, and thanks for bringing this to the forefront.
Yeah.
Thank you a lot for the comments. It's been really good. I mean, we are very happy that JSCAI is publishing the paper. We find that it's a phenomenal platform for dissemination of the findings. And I think that this initiative, this opportunity of having this conversation and discussing in depth, and also bringing many points that are not in the paper, is a fantastic, so to speak, complement to the published paper. So thank you.
Thanks for that, Javier. I could not have summarized that better. I really appreciate your contribution to the literature in this paper that's very important and published in JSCAI. But I also want to thank each one of you, Bill, Manos, Javier, for being here, committing the time, and adding to the information from the paper. And I want to thank JSCAI for giving us this opportunity, which I think is pretty unique and very valuable.